So the context is our secretary, Dima, asked me about executive quote unquote tests, which he should be doing or I'm doing on a regular basis. And initially I was about to send him to Function for their huge panel. But as you probably know, there is a lot of fluff. So I kind of trimmed it to what I do on a regular basis for all things prevention. And I created a document.
Let's give our viewers a context. So Alex and Alex asked me to join the nonprofit that he started. And what's the name of our nonprofit?
Living is Smart.
Living is Smart. So living is smart idea is that we all would like to live longer, and we don't think that should cost gazillion of dollars and $1 million a year. Our favorite influencer, Mr. Johnson's belief that that's what it should be, but we think that it should be equal with a full access to everybody, and that's why the nonprofit is there. So the idea is that we gathered a bunch of experts under Alex's and a few other people's careful consideration and try to say, what do we all need in order to live long, healthy life? So back to you.
Yes, and then I saw your post about Trump's health, and I was like, okay, definitely people don't see what normal range is versus optimal range is as well, and we'll get to that in a second.
Right. So that's a great point. So the point here is very simple. Looking at something from a medical perspective, what is disease versus not, is one thing. And that's not what we're going to talk about here. What we are going to talk about here, what is the optimal parameters for a lot of different markers that you should be striving at, not because you're saying, okay, I don't want to have the disease, but because you're saying, look, the optimal health is not the lack of disease. This is the complete critical component that the healthcare system is clueless about. And this is why we're doing this. We're saying, look, we're going to discuss some of the parameters and some of the markers that may not be linked evidence-based to specific illnesses, but we think that they're important, and what we will present here is based on our view and our synthesis of current best data.
Mm-hmm. So I put everything into a document, which we're going to discuss and then heavily modify, probably, because what I do doesn't mean that it's perfect. I definitely strive to get it better. And so let me share that screen.
Of course, this document will be always work in progress because the data in this subject is constantly evolving. So this has been recorded in June of 2026.
Preventative Health. Do you see it on the screen, hopefully?
Well, I see it on my screen, so
as well. Okay.
I have it. Yeah, I do see it. It's a little smallish, so for listeners, you may want to.
Yes, I'll first I'll zoom it in post, and second I'll drop the modified and improved guide to our free locations, so everyone could download it and use. I don't just go run on your own. You should always ask your doctor as well. So triangulate between all of us. But that should give a good start.
I'll reframe it slightly. I'll say if there are true abnormalities in any of your tests, those abnormalities should be discussed with your provider. We're not representing medical opinions here. This video is exclusively our opinion on what other optimal marker values for longevity and health, healthy long living. So if there's something that you're looking in your own labs and you have questions or concerns because there's some abnormalities, we're not including it in this conversation. Please do contact your provider.
So what I did here, I grabbed all my tests, which I do, and they all went into categories. And categories are more like organ or system oriented. There are some duplicates, and sometimes they are important for multiple. Let's say metabolic health might be important for cardiovascular and for brain health. So some markers will be in both places. Sometimes it will have different weight because they have different weight, obviously. But we can quickly go through all of them. What you think makes sense, and what am I missing, or maybe what I'm relying on too much. And yes, there are a lot of numbers and
Well,
unique
so let's
names.
go down. So there are a couple of immediate points. So the LPA, for example, right? So the LPA you just do once in your lifetime because LPA is a genetic marker.
Correct.
If you checked it once and it was normal, you're done with that one. You
Yes,
don't
yes. And I have it in the table in frequency once in a lifetime.
Right. If it's high, however, you may choose to do it more frequently, and you may try to implement different modalities to try to lower it.
Yeah, the funny thing is I just looked at what those guides, AHA guides, they were updated this year to actually include ApoB and LP-little-a into them. Only after 27 years after...
Yeah, that's okay. I mean, again, the idea here is again, it's a struggle between optimal and medical. It took that long to say, yes, this is medically relevant. If they're abnormal, they're contributing to significant morbidity, to cardiovascular morbidity, and you have to do something about it. We knew all of this for a long time, not from medical perspective, but because, of course, we recognized if these numbers are abnormal, they represent some problem. And the fact that current healthcare system cannot change this doesn't actually mean that there is no problem. So this is the difference. The medicine has to move with the idea of if there's something abnormal, do we have a tool, medical tool, to fix it? And there are a lot of things that we don't, like the LPA. There are no medical tools to fix it. They're about to be produced, but they're not here yet as of summer 2026. Will they be here in the fall of 2026? I don't know. Probably not. It'll probably be a year or so. But point being is, but then there are tons of natural methods that will help you to lower LPA. But that's not how a healthcare system thinks. If there's no drug, then there's no treatment. So similar logic is going to apply to a lot of things here. All right, coronary artery calcium. Tricky one. So why am I saying it's tricky one? Because I actually don't think that people should be doing it all that much. For a very simple reason. It's a pretty decent size amount of radiation. It equal to roughly 2 or 3 mammograms. And because of that, I'm worried. I'm worried about collective exposure to radiation in total. So I think that this test should only be done if there's actual significant risk.
And that's actually what I have in frequency once at the age of 40-50, and I would say to set up the baseline.
Perfect.
So if you have something going up in all other factors, and you have a risk, then you can reassess in 5 years, let's say, and see, okay, if it's progressing rapidly, then you should do something more advanced, maybe CTA.
Yep. So you got a lot of really good positions there. Like CRP is correctly positioned, exactly how I think. The blood pressure is how I think. Triglycerides, all this good stuff is really good. Exactly how I position homocysteine. I think everybody, no matter who you are, should have a homocysteine under 10. If you have additional risk factors, you could aim at homocysteine 8 or lower. Generally, I feel like it's almost an overkill because sometimes if you have a genetic, let's say you have the methylation mutation, MTHFR, and you found yourself in your 30s with homocysteine like Mr. Trump at 15, and you're going to say, well, what will it take for me to lower my homocysteine from 15 to, say, 8? You may not actually get there. That's a pretty dramatic alteration. It just may not be worth all the effort in chasing this number because once you get under 10, you probably gained 90% of benefit you could have gained. And again, there are some people advocating even lower, like Dale Bredesen in RECODE program recommends to below 8 for optimal cognitive health. Again, I would take that with grain of salt, saying that may be true for someone at the super high risk if your risk of dementia is not super high. Why? Like, what are you trying to achieve? So yeah, but I like how you positioned it. You had this 2 brackets, one from 8 to 10, another one is under that. Yeah.
And it's only yellow here because we're talking about cardiovascular health. Homocysteine is slightly toxic just by itself. when we come to
It's
brain health.
toxic by itself, but it's also a signal. If your homocysteine is very high, like if it's over 10, it's also a signal that you potentially have a whole bunch of other
Oh yeah,
toxins.
yes. I mean, everything is
not
probably
treating.
off because it affects methylation and your
Correct.
DNA expression, and then it kind of rabbit hole, which
Exactly.
is probably whole podcast deep.
Yeah, but this is a critical aspect that's medicine completely misses, because medicine thinks, oh, up to 19 is normal. Okay, well, that's because if you're above 19, the association with heart disease and strokes is so high.
Yes.
But that's, again, this is the struggle between what are you going to say medical and there is a drug for this versus, wait, that's completely not optimal. And, we're going to bump into the struggle again and again. In my opinion, homocysteine must be included in every annual screen for every person, except if you've had a couple of tests and they were all under 10. So if you're running routinely 7 and 8, and you've done a couple of tests and they're continuously at the same number, you're good to go. You don't have to bother screening it every year. But if you've been above 10 even once, you have to screen homocysteine every year. It's a very important parameter. In my opinion, is more important than cholesterol. But there's people going to critique me on saying this.
Well, I mean, it's a combination. It's like they all play a role.
Cholesterol is stupid. That's my favorite assumption. Cholesterol is stupid. Cholesterol is simply an inflammatory marker, nothing else, nothing more. It's just going to be responding to what's going on in your systemic what's your systemic inflammatory response. You may have some periodic worsening of certain inflammatory response. Cholesterol is going to follow. Homocysteine is a very clear marker how you detox and how your methylation works, and that's way more important parameter than cholesterol.
Okay, so you're saying it should be green here as well, not just in brain.
Oh yeah, it should be it should be a standard of care across every test in every population. It's not, because again, there is no simple, highly profitable drug to lower homocysteine, because obviously you can lower homocysteine with a diet, for cholesterol, we have this great statin drugs and a bunch of newer drugs, and that's why everybody wants to be checking lipids, because they can take a drug. I would arguably say exactly the same with homocysteine. We do have drugs. We have very effective B complexes of different kinds to lower it.
Is something making boom boom noises on your side?
Maybe it was just me doing my coffee. Which, by the way, benefits all kinds of biomarkers on this list.
Yes, except actually I've noticed, because I do have a mutation where I reabsorb cholesterol. If I eat eggs, my cholesterol just jumps through the roof, or if I drink unfiltered coffee, my cholesterol jumps through the roof. But if I do filtered, no problems at all.
So this also tells me quite an important point about cholesterol, right? So there are lots of things influencing cholesterol, a ton. And some of them influence cholesterol profoundly. Like, I will never forget, I had a case about 10 years ago. A gentleman came in because he didn't want to take statins. He came in just for the cholesterol conversation. And we were talking about, and I noticed he had a very high stress in his life. So he had a very high cortisol. So instead of giving him a bunch of supplements, I said, why don't you join our mindfulness-based stress reduction program for 8 weeks? He had 50% reduction in LDL. Wow. 50%, 50. It went from 160, I'll never forget, to 80.
Yep, that's amazing.
And just from doing stress reduction alone. And so we're like always assuming that cholesterol is this biochem. The system will respond to all kinds of things we do to it. And many of them are completely not related to biochemistry. They could be purely mind-based. They could be purely spirit-based.
Your mind is still in control.
Exactly. Now, that of course doesn't happen to everybody. But
let's move to metabolic glucose regulation.
So I just want to highlight one critical point here that people often don't understand. Hemoglobin A1C is really not a good screening tool for anything. I don't even use it anymore. I only use it once I identify a patient who is either diabetic or pre-diabetic. Then it's a useful tool. If you never had those problems, HOMA-IR, which you correctly pointed in green, is probably the most.
I have like caveats here to this test, that it can be falsely low, falsely high.
Correct.
Your blood.
Very problematic test. I once by accident, actually I've done it several times, I sent the same test by accident. I ordered it twice on the same patient. And I started to know, this was first time when I noticed this, there was a 0.5 difference between two labs drawn on the same day. So then I did it several times more, and so the variability in A1C in a person who's not diabetic can be half a point easily. Same exact blood collected at same exact time. So the test itself is not precise. That's what I'm trying to say. It's not good at low numbers. At low numbers, it's highly inaccurate.
So I'm kind of a fan of CGM.
Yeah, so let's come back to them, but let's just talk for a second more about HOMA-IR, because I actually think it is the most important screening test. We'll come back why I don't consider CGM routine testing. HOMA-IR, at the way you're written, first of all, no one should be living above 2, not 2.5. I think that's a population average.
Population, yeah.
So I think optimal, well, I don't think you need to worry about getting under 1.0. I think 1.5 is a good cutoff. If you want to be more strict, I'd set it up at 1.2. That's the way I think. I think you can arguably say, 1.0 to 1.8 acceptable. Yeah, no, these are all like, this is not precise. If you're living if you're living under 1.5, don't worry about any of this. It's perfectly fine. Just for listeners, it's a critical value because it's a value of a combination of your fasting glucose and fasting insulin. And I'll tell you one critical aspect. I have seen thousands of patients, not hundreds, thousands of patients misdiagnosed with prediabetes because somebody will run their hemoglobin A1C. It'll come back at 6.2. They will have their fasting sugar at 120, and they say, you're pre-diabetic. You're on the HOMA-IR, and it's like 0.8.
What's going on?
I see this probably once or twice a week. I'm not kidding. It's that common. And those are misdiagnosed cases. Those people do not have prediabetes. They have something called dawning effect. Where earlier in the morning, the sugar follows the cortisol curve. And you get this short-lived spike that has zero impact on the overall health. In fact, it typically signifies a super robust metabolism. And those people are actually protected against metabolic syndrome and against prediabetes, but they get labeled prediabetic. I've literally saved grief for hundreds of, for some reason, mostly older, thin women. Because they were all labeled pre-diabetic, and I tell them, no, stop your metformin. You don't have any pre-diabetes. This is baloney. You don't have any problem. That is the value of HOMA-IR. HOMA-IR is just a lot more accurate than using A1C and purely just fasting glucose, which is what system currently does. So there's a lot of inaccuracy. That's one. Why am I fan and not so fan of CGM? CGM is amazing when you're actually trying to do something about it. When you're saying, okay, I'm going to change my diet. But using CGM as screening is a disaster. There's a lot of inaccuracy. People often stick them wrong. There's a lot of variability. You need to know a lot of tricks of what not to do when you're placing them. I've had people coming into the practice being completely mad that CGM is 150 just to recover, that they stuck it in the wrong place. And for 2 weeks, they were like walking around being so scared that they're diabetic now. So you have to be a little careful. It's a tool. It's getting better. I think it's rapidly improving. I think it's a critical tool for anyone who's saying the following: how do I change my diet to improve my sugar? Then you have to use CGM. That's the best available tool, because you can literally measure the sugar right after you eat something for the next couple hours and see that this particular food does this to your sugar. I use CGM and found that grapes are bad for me. Like every time I would eat grapes, my sugar will spike 50 points, versus I'd eat much sweeter foods like bananas. Nothing happens to the sugar whatsoever, not even a little bit. Why? Fascinating question. There are certain ways. Sometimes you may be allergic to food or sensitive to food, and that sometimes spikes the inflammatory response, and with that the sugar follows. Sometimes you're simply processing certain sugars differently, because each fruit or vegetable often have a slightly different variations of certain types of sugars and a fiber, and that's how we absorb. So the fiber slows down absorption of sugars, and you may have different parameters of how the sugar goes up after. So if you're really interested in that, definitely CGM is great. The frequency is unclear. I often recommend CGM, not necessarily even as a baseline. I wouldn't use CGM as a baseline. I would only apply it for people who are ready to do something with the result. I mean, I wouldn't, if I have someone with a normal HOMA-IR, I would never suggest CGM, just FYI. That's how I think. But I don't see any value of, like, I don't see any problem applying it, because you may just, no matter what you do, pick up really interesting information. So if somebody's really want to do it, I never say no, I just order it.
Yeah, it's very interesting. Definitely when you first time insert it in yourself, first couple of weeks is like, oh my God, holy shit.
If you're a listener and a geek on this topic like Alex and I, definitely do it. Like, you're gonna learn so much new information about how your sugar follows your diet that you're gonna thank us.
And it's not just diet, it's like quality of your sleep, stress.
Right.
If you go for a walk after a meal or not, it's like
it's profound. It's profound, and you're gonna learn not just how to optimize certain things. You're also gonna learn where your weaknesses are. So remember, one of the biggest reasons why we're having this conversation is, as you kind of gradually get engaged with all these tools, the wearables, the tests, etc., you starting to identify the weak links in your health. And that's where you need to concentrate on. You know, there's no point trying to, if you already have a, body fat at 8%. I'm telling you my number. Like, there's no point going from 8 to 7 or 6, or thinking that somehow if I drop from 8 to 6 that my health will improve. That's a total nonsense. Like, it's just waste of time. But, I know my relationship with certain foods, may be a little bit healthier. Like, I tend to sometimes, I have a sweet tooth. So for me, the CGM was really valuable, because I said, oh, that's funny. I can eat watermelon without really thinking how much of it, but the grapes, if I eat more than a handful, I'm in trouble. So these are the things you need to do, simply because if you don't do something like that, you'll never find that out. Because if I run the average test, or if I run fasting test, I'll never pick up the grape effect, because it's just going to wash out for the fasting, and it averages down a lot lower. My A1C sometimes like routinely under 5.
Yeah, just definitely challenge under the load, which I like in this situation.
Exactly.
So what do you think about other tests? I think the new ones like C-peptide, more insulin indices.
I mean, C-peptide is good. I don't use it because I just don't.
I don't use it either. But I mean, like, should not?
Well, I don't see an additional value. If you're running HOMA-IR, I don't fully understand what will it add, or how will it change, or like between HOMA-IR plus CGM, like. How is this going to change anything?
Yeah. That's why I'm like, I know that my insulin is usually around 5, so I'm like,
I can see a potential value down the road when there is a discrepancies. So let me give you an example. Let's say you run HOMA-IR, and it seems to be okay, but your A1C is persistently very high. I'm talking not like, 5. I'm talking about like 7. Well, then there may be a value in running this, because you're like having something really bizarre here. And that does happen occasionally. Invariably, in my experience, that was with A1C was wrong. So that's why I'm relying on HOMA-IR like a Bible pretty much, and I haven't learned, maybe it's also because I haven't learned more advanced applications of other things, and probably also because there's just not enough experience yet with some of these newer tools. I think they'll be here very soon. The fasting insulin has been around forever and ever, and so HOMA-IR in essence is nothing new. It's just a calculator that's
you just divide one over another.
Yeah, it's just a calculator, but over last 10 years it became really standardized with tremendous amount of evidence. That's why I think I like it, and also because it's very easy to follow. It's not an additional new test that has to be covered by insurance or expensive. It doesn't cost anything. I mean, it's not a new test. It's simply synthesis of fasting glucose and insulin, which you should be checking anyway at every blood work you do, probably. Unless you, like me, so protected against prediabetes that you don't really care. In that case, don't worry about it.
Yeah, I just remembered that one thing I've seen recently, also from the studies, and that's why CGM might be useful. Your sugar, how it reacts post-meal after 2 hours. Like if you drink something very sugary, you can just see what happens with your sugar. If in 2 hours you robustly go to the baseline level, you're good. You don't even need to check your insulin or anything. The system works.
Exactly. Yep, exactly. Remember, we did this crazy test that we would have people drink this like horrible
glucola.
Yeah, and then we will check sugar and insulin.
Check.
I was like, oh my god, like we used to subject.
Freaking annoying.
I stopped doing this after I did this test on me, and I almost passed out after drinking that drink. I was like, oh my god, I'm not subjecting anybody to this shit. It's horrible.
Yeah.
You know, thank God that soon after the HOMA-IR started becoming so standardized that I haven't ordered the, what was it called? Glucose challenge test, I think. I haven't ordered that in like years because I don't have to anymore. So.
Okay.
All right, so
Thyroid.
Really good. Okay, so obviously this the TSH and free T4. I would arguably say the system tells us not to check T3 on everybody every time.
But you do panel anyway?
You know, it's a tricky one. It doesn't add up a lot of cost. I often check T3 on a lot of people, even if they're running not on any kind of thyroid medications, but it's a little bit tricky one. I don't routinely check antibodies. I only check it. I don't even check it at baseline. I only check it when I'm worried that there is some kind of an inflammatory component. So if I'm noticing patient has some kind of inflammation or any kind of autoimmunity, I would run not just TPO, but a full panel. You know,
that's kind of what I think this comment pretty much says here.
Yeah.
Just do it maybe once, and then if something going on weird, then you should want to check it.
Right. Yeah, I think it's perfectly reasonable to run it once especially if you have any genetic predisposition to any thyroid problem or to any chronic autoimmunity. Then I think it's a very valuable test.
So what would you say? Like I'm reading this. What about normal versus optimal? Is anything?
So
or you always need to watch for both of them?
Yeah, so to me, your range is perfect. Except one thing. I wouldn't, if somebody is way under 1, even if they're like at 0.3, for example, or 0.2, usually I'm not worried about it. The reason is now, if they're routinely at 0.2 without medication, without thyroid replacement, I may be worried about it. But if I'm replacing their thyroid and it took me to get the person to 0.2 and free T4 and free T3 are normal, I'm not going to worry about that low number. So, but definitely the optimal range is less than 4 or 4.5 as the normal labs say.
Yeah. That's another one of those where you don't want to be normal, you want to be optimal.
No, but will I initiate the drug at the level of 4.5 or 5.0 or 5.5? No, absolutely not. I will use a variety of natural methods to lower it. And there's a lot of things you can do to optimize thyroid function without taking medications. This is a very poorly understood topic. Everybody comes in with, with this gray area between 4.5 to 10, and their doctor says, well, I'm not going to prescribe medication because there's no evidence, and the doctor is correct. But it doesn't mean you should be doing nothing.
Yeah, exactly. Yeah.
This is like often, if there's no drug, then you just go home and live your life. That's not true. I mean, you can do a lot of things. You can optimize an iodine intake. You can optimize mineral intake like selenium, zinc, etc. So there's a lot of things that should be done. And also, when you're in a gray area, you probably should be checking yourself for other problems, because in that
is it
gray
absorption,
area,
or something else?
Exactly. In that gray area, there's a lot of issues that may be surfacing if you look deeper. So optimal range is exactly what you have up there. That is not optimal. Like I would put 0.5 to 2.5. But yeah, that you look at, like splitting hairs probably doesn't. All right, let's keep moving because I only have about 10 minutes left.
Okay, liver. Anything?
Yeah, so really important marker is GGT.
Yeah, that's something new, right?
I'm glad how you emphasizes it. Functional GGT should be under 25 or at least under 30. Definitely not above 30.
Well, my optimal range is 10 to 17.
Wow, that's too narrow. I mean, I think under 30 is fine. And you don't have to worry if it's like single digits. It's not a problem. When it's really low, it's okay. But it is a really important marker because it's in contrast to ALT and AST that usually represent inflammation of the liver. GGT is an actually functional marker of toxins in the system. That is, people often don't realize. They think that it's another AST, ALT-like marker, but it is not. That's why GGT we use in every test pretty much when we really worried about any kind of toxicity. So
yeah, it's kind of underrated, I would say, right?
yeah, very heavily underrated. The cystatin C is this new kidney function marker that's gaining rapidly popularity. I started gradually using it more and more. The reason is it's much more accurate. The problem with using creatinine and eGFR that it's based on
Yeah, it's a
lots of
calculation.
different things.
Yeah.
Exactly, it's a calculation. You have to include age, sex, etc., etc. And
Yeah,
plus,
and you have to stop, I think,
there's another
taking
problem.
creatine if you're taking it like for
Bingo.
2 weeks prior,
Exactly.
which is annoying.
Exactly. And you wouldn't believe how often I start getting grief from other providers when I would put person on creatine. Their creatinine goes up by 20-30%, and then I get a call from their renal doctor.
Because it messes up every single lab.
Exactly. So that's when the cystatin C is so valuable, because that's not going to change. It's going to come back completely normal, and you're kind of quieting the doctor saying, look, it's a permissive increase in GFR, because it's not true. It's just the way that creatine gets metabolized. The creatinine goes up. And
Anything to add to subtract here?
No, I like it. It's really thorough. Now, the only thing with cystatin C is I would not use it as a routine test.
Yeah, it's kind of expensive.
Yeah, it's expensive, but I use it more.
That's actually what I have here, more expensive. So
there you go. Yeah. So stick with GFR. When you start creatine, expectedly your creatinine gonna go up by 20-30%, somewhere in that range, and it's completely okay. It will go up and it'll stay up. It won't necessarily keep going up and up. It'll just go up right away after a couple of weeks of taking creatine and just stay there.
Yeah, so my strategy for frequency is to do cystatin like now and then, every 3 years.
Yeah, that's good.
Just to double check everything, because I think
I think that's very smart. I think that's I haven't started doing it this way yet, but it's coming for sure.
Okay, inflammation.
Yeah, so here you have a little bit of an issue, right?
Yeah.
So we already talked about this. So neither uric acid or heavy metals are markers of inflammation. CRP is the most important one, but I use a lot of others. So
like talk about them more.
So I use TGF beta 1 quite a lot. I use C4A quite a bit. We use MMP9 quite a bit.
ILs, IL-6?
IL-6 we use quite a bit. Other ILs I don't use as much. Sometimes I would use IL-1 and 2. The 6 is important. So all these markers I just mentioned, they're coming up in patients who are exposed to mold, while the CRP remains normal. So this is critical. So CRP would be normal, but all these other tests will be up. That's how I would know we have a problem.
Yes, something is off. Okay, so do you do it annually or like?
I would do them when I first screen the patient into the practice. If they come back reasonable, then I wouldn't do it routinely unless there's something changes, like symptoms change, they got exposed to some crap, etc.
Or move to a different place.
Or move to a different place. Those tests are much more expensive.
Yep.
CRP is very inexpensive, and everybody should have it done at least once a year, if not twice a year. And that's also really problematic if patients with many insurances, particularly with Medicare doesn't want to pay for this test, which I find it really crazy. You have to have special codes to authorize it.
That's kind of separate conversation, but I think we could build for our listeners panel on Rupa for its price, which is going to be like what, $25, and everyone could go and order it.
Exactly. CRP is very cheap. CRP is very cheap test. There's no reason not to order it. It's hypersensitive. That's the only thing I would mention. So you may have a sniffles.
Yeah. Same kind of as homocysteine. If you have an infection going, your inflammation markers are going to be all over the place.
Homocysteine, not really. Homocysteine takes a couple of weeks before it changes. CRP takes a couple hours. So that's the difference. Yeah. So they're both active acute phase reactants, but they respond time-wise a little bit differently. CRP is like crazy acute phase reactant. Like you sniffle and in 2 hours, it's already up.
Okay, what about uric acid? Do you do it at all? Skip it?
So I always use it in an initial screening. If I find it anywhere above 5, I often routinely screen for it ongoingly. The reason for that is you just don't know at what point person gradually will start increasing. There's also a lot of methods to lower it, like nutritional methods. Vitamin C, quercetin.
Drinking less.
Yes, less alcohol, less red meat.
Less red meat. Yep.
Will-
Yeah, I have it there.
Yeah.
What are heavy metals? Is this?
So they're not really inflammatory markers. I mean,
Yeah,
missing-
they probably deserve their own
they
page.
deserve their own. I think the toxicity deserves its own
Yes.
panel. I would put GGT in there, not in the liver, and I would definitely use heavy metals in there, potentially some other stuff, but that's kind of beyond today's conversation. But I think screening for toxins in the future is going to be even more important than like thyroid tests, for example. Why? Well, because I'm expecting that our environment is going to be increasingly more polluted.
Yes, pollution accumulates, so we get more and more exposed every year.
There is a test that I love, which is called Nutrival from Genova, that actually has a universal exposer, metabolite of universal exposing toxins, gasoline and styrofoam.
Yep.
We expose to those toxins pretty much all the time. Well, styrofoam gradually will disappear, but the gasoline, that's not. And so if you check for metabolites of those toxins in the blood or the urine, and if they start going up, that's a best screening test. Heavy metals are tricky because we currently check them in the blood. That's not the right compartment. In order to be accurate about heavy metals, you should be checking blood cells, either red cells or white cells.
Yeah.
Most labs don't do that. Yeah.
So frequency on those.
Hard to say. I would say if they were abnormal, definitely.
Then obviously you fix them, you detox,
Otherwise,
whatever.
I think it's very reasonable. Every 3 to 5 years, I think it's really good plan.
Generic hematology. Well, I don't know. Anything to add?
Again, I would put ferritin and transferrin into nutritional, right? Because it's more of an iron. Beyond that, the CBC is a standard test. I would do any more than that. With differential, just the way I said. Every time you draw blood work, you probably should be checking CBC and CMP anyway. So, yep. Yeah, so this is a fascinating.
Yeah, our favorite.
We can spend 2 hours on it.
Yeah, so let's just compress into what to add, what to remove.
Well, the ferritin you could throw in there. Omega-3, the problem checking omega-3 is the labs are awful about it. The LabCorp and Quest are not accurate enough.
I use the Mega Index.
It's just crapshoot. I like the only actual index I like is Genova Index, which gives me not just the index, but it gives me a detailed explanation of each fatty acid. I do like to look at it. Like I like to look at DHA versus EPA.
Quest now has detailed fat panel.
Yeah, they do. I don't trust their essay. That's the thing. So I'm gonna gradually do more of them and collect the data. But so far, I've seen a lot of discrepancies. So I would run Nutrival and Quest comes up with completely different result, which to me says
Nutrival kind of wins. So that's kind of worth noting here. Would you recommend doing Nutrival for everyone every year?
No,
it's kind of expensive test.
No. It's an expensive test. It's not that expensive. I mean,
it's not as much as expensive as annoying. Also,
it is an annoying test because you have to get that kit. You can't go to the LabCorp to draw it. You have to have a special blood draw. It is annoying, yeah. So, I mean, if the patient has any complex illness, I always order it on an intake. Subsequently, after that, it's very dependent on the story. Sometimes once a year, sometimes every couple of years, sometimes never if the patient is doing well with a treatment plan. So I don't really look at it this way. I look at it more as a kind of a fishing net expedition. I'm trying to catch something.
So it should probably be here also with like gray mark. If you have some issues, you know about them, go do it to create your baseline, and after the treatment, maybe redo it too.
Right. Whenever you get zinc, you always have to get copper. They have to go hand in hand. They have to go together. Why? Because the high copper is a problem, low copper is a problem.
Yeah, they balance each other.
And they balance each other. So you want to always have some kind of a balance. Taking copper is very problematic. Most of my patients don't need extra copper. You'll get enough from food, but a lot of people need extra zinc. So that's why a lot of the multivitamins that I like to use, they will have zinc but no copper. And so if you're taking multivitamin with copper, watch out. Those are the patients who get in trouble. Excess of copper causes Alzheimer's disease, so you have to be very, very careful with the overtaking amount of copper. You have to
Any tests, markers here to add?
Selenium for sure. I routinely check it on a lot of people. Definitely B1, B6. I check quite regularly as well. Not on everybody. Occasionally, I would run vitamin C and vitamin E and vitamin A. Why? It depends on the scenarios, but it's very common for certain people to have a very low vitamin C levels. Those are the people who often need to take high doses, like 1 gram twice a day for a
Like slow
very
release or
long
something.
time. Yeah. Well, because some people consume certain nutrients at much higher levels, so they need to simply eat more. The B vitamins, same thing. Like, I've picked up a lot of B1 deficiencies by screening. So you have to just be a bit more aggressive. But that's a more general screening test that you have for like routine labs every year. So for those, I probably wouldn't necessarily include them. Yep, so hormones look good. Now, in men, I wouldn't run estradiol and estrone regularly. Sometimes I would screen it once, but rarely. Definitely testosterone, most men at some point should have run.
Yeah, I would say those tests are probably needed if you're doing hormonal replacement and when you're finding your perfect sort of amount, then you probably
I don't use a lot of IGF. I like how you put that gray box in there. I don't necessarily like it. I think it's very unpredictable often, and it's sort of like it's hard to figure out exactly how to use it. So it's still very debatable test. PSA, I basically base on person's risk and their desire. So like if really concerned about prostate cancer, I would screen it on a very regular basis. If the person comes in their 70s, they're not caring about it, I'm not going to even order because 80% of men will have prostate cancer.
From what I've read, it's kind of nice to me because it's cheap test, and if you have your curve, and if it suddenly accelerates, then you're like, okay.
I completely agree with you. I completely agree with you. The reason I don't necessarily advocate for everybody is because it depends on your personal preference. Like if you want to have more numbers, the problem is that even when it starts accelerating, they go up if you're in your 80s.
Well, yeah, of course, if you're 80s. I mean, I would still probably then do 4C score test because it's very accurate.
And PSA should always include total and percent free. It should not just be one number. That's very important.
Okay, that's a good addition. Yep. Yeah, I'll make sure to add it here.
Yeah, if you just do the total, you may miss a lot of early cancers when the free drops.
Correct. Yes. It's kind of got aggregated into one here.
I love morning cortisol. I check it on almost everybody very routinely. It's one of my routine tests, even though, again, if you look at the standard of care, that will not be the standard of care.
Well, if you don't want standard, you want optimal.
Yep.
Anything to add to this panel? To this page?
Yeah, I mean, I do a lot of cortisol curves.
It's kind of missing the woman hormones here. I would say
right. It missing women's hormones. So, but hormones are very advanced and sophisticated. Like for example, cortisol, I often run the pattern throughout the day in saliva because it's a lot more accurate test.
Yes, you want to see your curve.
Yeah.
All right.
All right, let's do last category, and then I have to go.
Yeah, we almost.
Yeah, so body composition, it's kind of interesting. I don't necessarily tell everybody to get it, but I think the percent fat would be really valuable. We're probably close to have all this equipment being basically almost like wearable. There are devices for $200-300 that will give you a very accurate body fat percent nowadays. I think in the future it has to be like everybody should use them like once a week. Just like at some point I told you that the cognitive test should be done once a month. I think we all should be running the body composition tests very regularly.
Okay, let's just quickly drop into cognitive and then we can wrap it up.
Yeah, because this is right. So you kind of have a little bit of a mishmash here, right? Some of them are tests for cognitive, actual for Alzheimer's, like p-tau and ATN. And some of them are risk factors for Alzheimer's. The rest of them, the fasting insulin, sleep apnea, homocysteine, those are risk for Alzheimer's.
Yeah. So see, it's like homocysteine is green here. Right. So it got elevated in status.
Right. So one thing I would definitely add here is the BOCA test. BOCA test is direct to consumer. You don't need to have a doctor. This is why I'm not advocating for MOCA, because MOCA, it has to be administered by a provider. So you have to go somewhere to do it. But BOCA, Boston Cognitive Assessment, which is, you can go to bostoncognitive.com. It's a free test. You can do it. You can set up your own account and routinely check it. So then you have a tracking. Why it's important to do it monthly. If you don't track it, occasional variation is going to be meaningless.
Noisy, yeah.
Noisy. You're going to wake up with a hangover or whatever, and you're going to perform poorly. And the next day, the number will go up by 2 points. And what does it mean? Nothing. It just simply means you need to average things and you need to track it for a prolonged period of time. That's why monthly for healthy people is probably the right target. When we're working with patients with Alzheimer's, they do this test weekly, once a week. So.
Yeah, maybe just put it into your calendar and do it on, I don't know, Sunday afternoon now and then. Anything?
I think we should have a take 2 on this. I think this is really cool. We should do more of this. So let's have this a little fine-tuned and get together and spend a little bit more time.
All right. Yeah, sounds good.
Right.
So I'll
everybody.
have the link below for everyone to download this. Thank you, Michael, and we'll talk again.
Bye.